the single biggest driver for all our discussions is our costs. I mean, at a societal level, that's really the driver of the changes in the healthcare system. We saw it in a number of the discussions, but we're aware of the fact that these are quite large proportions of our gross national product, and we have to find some way to deal with costs. When we deal with costs, we then challenge ourselves about the quality equation, and then we end up with value, and we create value-based purchasing. There are some who think that value-based purchasing will have this dramatic effect, but value-based purchasing will affect us only when it really exerts enough pressure to change behaviors. And when we look at the behaviors that have been suggested, there were comments today about standardization. If we standardize care in certain arenas and delivery of care, and I come from the healthcare provider side. So I believe that there is room for standardization, but I think you almost have to bifurcate your considerations there. It is true you can standardize and modernize, as it were, certain surgeries, cardiac surgery, hip surgery. I mean, there are a number of areas of medicine, and I think Don alluded to this morning, when there is an opportunity to improve, let's improve. But if we go beyond that and realize that on the other side are the chronic conditions, the much more complex comorbidities, and that there's a tremendous variation on that side as well. And then we have to challenge some of our assumptions, because the Dartmouth group made us believe early on that this variation in care across the country, same result, higher costs. Gwande's article in the New Yorker talking about McLaren, Texas, this idea that we just have variation in what we charge or what we pay. And then that sort of had to be set aside a bit by the Institute of Medicine study in August of 2013, which showed that most of the variation in care across the country is really in the post-acute arena.